Hello and welcome. I am Chris Hemphill with Wobot Health Meeting of the Minds, and I am joined by Dr. Aaron Friedkin of Homeward Health. And we're excited to bring a conversation to you straight from Detroit MedHealth Summit. So the MedHealth Summit is an annual event that brings together technologists and other folks in the Detroit area, especially in the healthcare technology realm, to connect, network, and grow their businesses, grow their understanding, and grow their mission. I'm extremely excited to talk to Dr. Friedkin today, who comes from Homeward Health, which is like, when we think about these concepts around disruptors in healthcare, this one goes even deeper than that. Because the common framing of the disruptor has been like a completely for-profit motivation. Our common framing of these healthcare disruptors are tech companies coming typically out of Silicon Valley and operating typically on short horizons and things like that. But this concept, we had a really fascinating conversation earlier about this concept of a public benefit corporation and how they stay mission focused on healthcare equity and driving healthcare outcomes in rural health areas. So really want to dig deep on that, focus on their strategies, their focus on innovation, and just get deeper into Dr. Aaron's background on how he came from a pediatric radiology perspective to now working on the business side. Aaron, I'm going to put you on the spot so much because we've got so much to talk about. Any words for the audience before we get in?
So first of all, just appreciate the opportunity to be able to speak here at the MedHealth Summit, and then with you, Chris, as well. We're really excited about the work that we're doing at Homeward, and I love to come back to our mission, which is to re-architect the delivery of health and care in partnership with communities everywhere. And there's a couple words that are part of our mission that are really deliberate, and you hit on part of this. The first is this idea of re-architecting. We didn't come out and say that we're going to reinvent or reimagine. We said there's a lot of parts and pieces that exist in the system today. How can we put them together in a way that actually supports underserved populations? And then the second word that's really critical in our mission is this idea of partnership. And that historical way that a lot of disruptors in the healthcare industry came in and said, we're smarter than everybody else, we're going to figure this out. I don't care that you've been doing this for 50, 60, 70 years, we know better. That's not the way that we're going to solve the challenges that exist in delivering care to rural America. We know that we have to do it in partnership with the communities that we serve, with the trusted entities that exist in the system today, as well as just other members of the healthcare ecosystem. So thrilled to talk about all of that and anything else that you want to touch on. So.
All right, fantastic. And I hope that the audience hearing that is getting excited, because you're going to hear a lot of stuff to write down, especially when it comes to looking at the disruptor not as a disruptor but as a potential partner. Mm-hmm. I know that our audience has a lot of people in the traditional care space, but I see even innovation on the traditional side and questions around how can we partner with newer players in the types of innovations that they're creating. So we're going to get deep into that, but it's always most important. Let's always remember that behind every innovation, behind everything that you see, behind every change that you make, behind every strategy you make, it's about what people are doing, like how people's backgrounds have led them there. And Aaron, you bring just such a rich background with pediatric radiology training at Harvard, time at McKinsey, Blue Cross Blue Shield Minnesota, and now all the way to the new entrant space. So could you just talk about your personal mission and journey and how that's led you here?
Yeah, so thanks for asking. I wouldn't go so far as to I've had an interesting background, but I think I've had a unique background. And as you mentioned, I'm a physician by training, so I'm thrilled to be here in Detroit. I'm a loyal Wolverine. Did my undergraduate training at the University of Michigan, did my residency there, and practiced as a pediatric radiologist in the Twin Cities in Minneapolis, St. Paul. And for me, what I learned, and I tell people this all the time, is that I liked the path to become a physician a lot. But then when I was out in practice and kind of just doing the same thing over and over again every day, for me, there wasn't this next thing to be working towards. And I became really intrigued by how can we make our practice more efficient? How can we grow our practice? How can we do new innovative things? And I realized pretty early on after I was in practice that I wanted to be more on the business aspect of the healthcare delivery space to really think about solving some of the big problems that I saw. So as you mentioned, that ultimately led me to an opportunity to work for McKinsey & Company, which is a large management consulting company. Had the chance to work on really big, ambiguous problems for payers, for providers. And that's really what motivates me. I like tackling things where there's not a clear answer, but you've got to think about how do you move the problem forward. And after a few years at McKinsey, ultimately that led me to work for the health plan space. So started at Blue Cross Blue Shield of Minnesota, where I basically was the medical director that was working with all of the large employer groups that they had there. So as you think about many of the disruptors that we see in the healthcare space, they're oftentimes working with large self-funded employers who foot the full bill for the services that they have, the healthcare services they have to cover for their employees. So I really got deep in understanding what are the pain points that those companies have, what are the opportunities that we actually have to support their populations. And through that work, it's funny, I was talking about this with someone the other day. This was going back in 2016, 2017. There were two things that I was talking with employers about at the time that they should be focusing on. One of which, I remember I was in charge of working with the teams that did all of our customer reporting and analytics to look at the employers' problems. And I would tell the employers, I don't care what your data says, whether you're spending too much or too little on behavioral health, that's where you should be focusing your energy.
Interesting.
I said, so this is, and not that people weren't talking about them, but I think we were a bit ahead of the curve back at Blue Cross Blue Shield of Minnesota. And the other thing, I posted, I wrote a whole blog article about this. I told employers, if there's one thing that you could actually tactically do, it's educate your employees on washing their hands. So think about this in 2017, 3 years before a global pandemic, and people at the time looked at me like I was crazy. But there were actually really good studies that showed if employers actually educated their employees on proper hand hygiene, you prevented transmissible diseases, absenteeism. So anyhow, got really invested in understanding what self-funded employers were doing. And then that ultimately led me to Blue Cross Blue Shield of Michigan. So I had a chance to move back to Michigan and got to lead commercial strategy, clinical strategy for those types of employers, really focusing on what are the opportunities to support their employees in different ways. Had the chance to deploy a number of new digital health solutions. So I kind of built the strategy for digital health at Blue Cross Blue Shield of Michigan. And that's where I got exposed to a company called Livongo Health. So you may be familiar with Livongo. Livongo, chronic condition management company, was purchased by Teladoc a few years ago for an astronomical amount of money, like $18 billion. But that's where I started to see the value that bringing new types of solutions to support populations and thinking differently could really deliver value. And then in my last role, where I was at Blue Cross Blue Shield of Michigan, I had the opportunity to really think through new ways of paying for care. So how do we bring this concept of value-based care where you're paying for outcomes and quality and managing down the total cost of care in a way that makes sense for patients? And that's where I got the bug. This idea of really thinking about aligning incentives between the people that are paying for care, the people that are receiving the care, and the people that are delivering the care. And that's ultimately what led me to Homeward. And Homeward was founded, our CEO and president both came from Livongo. So that's how I got to know them. I was a customer. I think they might say I was a bit of a pain in the butt customer. Good. Because I was pretty demanding. But
the best kind of customer.
Exactly. But when I saw what the company was trying to do, it was a really unique opportunity for me to bring the learnings and value, all the things that I've learned about through my experience, and align towards a mission that I'm also very passionate about, which I'm happy to talk about what we're doing at Homeward.
Great. Well, just a couple of comments is that
You said not interesting,
but then you just blew us away with that. So,
well, thank you.
Just got to throw that out there. And there's so many interesting conversations to be had. when we think about a digital health strategy and the many different vendors and different players out there, questions people might have overall would be, well, how do you manage the connection between like 20-something plus different vendors, and how do you hold them accountable like you were doing with Livongo? Unfortunately, that will have to be the subject of another talk. We can get a little bit deeper into Homeward Health, but there's just so much that I'm excited to unveil in this based on your background that you just shared. But let's just narrow in a little bit on Homeward Health, because we're talking about the mission, we're talking about the focus. My next couple of questions are, like, what is Homeward Health? What do you focus on? And then how does this role of Chief Business Officer apply in that?
Yeah, so Homeward, the way to think about Homeward is we are a new, the buzzword technology-enabled, value-based care provider that was really designed from the ground up to think about how do you overcome the challenges of delivering care to the rural population. So when you look at the United States, about 20%, about 60 million people of the United States population actually live in geographies that are considered rural. And unfortunately, when you look at the statistics for the rural population, the health outcomes are horrible. So about 40% higher preventable admission rates for people that live in rural areas, 23% higher mortality rates. So just based on where you live, 23% higher likelihood of dying. That's unacceptable to us. So as we said, there's a really big problem to go out and solve. How can we think about doing this in a way that we think is going to actually solve the problem and be a sustainable business? So what the team from Livongo really understood is this idea that there's a way to leverage technology to scale the way that you can deliver care to populations. And when you look at the rural population, it's not the only driver, but one of the major drivers for some of those outcomes that we talked about is a lack of access to care. So we just know if you live in a rural area, you have about half as many providers on a per capita basis. You live in about 2.5 times as far from a hospital as if you live in a more urban area. So the solution isn't go build more hospitals and try to get providers to move to rural areas. That's not the way that you're going to solve this access issue. So the idea from the start was, how can you think of creative ways to scale the way that you can expand that access? So knowing that we'd have to do something different to solve there, it became really clear, and this is where my background, you talked about what do I do as Chief Business Officer, a lot of times it's starting with, how is this going to get paid for? And what was very obvious to us from the start is that we couldn't be constrained by the traditional fee-for-service way that care is paid for. If we just said the only way this business is going to work is by making sure that we get paid for every service that we deliver and that volume over value space, that's not going to work. So we said, imagine a situation where we were given a certain amount of money to manage the population, deploy new and unique tools and capabilities and service models, whether that's virtual visits, whether that's going into the home, and not trying to solve for is each one of those individual services going to be reimbursed on their own, but thinking about how does that constellation of services actually support the needs of the population. We said if we have a way to do that, that unlocks a tremendous potential for us to do something different. So fortunately, those ideas of what we call capitated payments, where providers just get a block of money and you're at risk to manage the population. You have to manage within that dollar amount. Those models actually are becoming more and more prevalent in the Medicare space. So we said, all right, if we're going to solve this population, we're going to prove out this model, we need to start in the Medicare space because it's most aligned with this opportunity to take on capitated payments to serve a population. So the other thing that we realized was to do this, we couldn't just be a vendor. We couldn't just say we're going to pick and choose different health plans and we're only going to serve a certain portion of the population. We knew that we want to make sure that any Medicare patient that's in these rural geographies we serve can access Homeward's model. So we were very intentional. We are not, when we enter a market, we enter as an actual in-network provider with the Medicare plans that are there. So that's both traditional Medicare and the Medicare Advantage plans. So that's just a very different approach than many other organizations have taken because, again, we don't want to turn patients away if they actually need care. So that talks a bit about the business model. So what do we actually do? So when we enter a market, we are basically have immediately expanded access. We are a new primary care practice that exists in the market. We don't build brick and mortar facilities because we knew, I think we joke internally, no matter where we would have put one, we would have invariably picked the wrong location. So what we said is, how do we take away the constraint of having brick and mortar? Well, why don't we meet people where they are? Let's go into people's homes, if that's an opportunity, if that's where they want to receive care, to eliminate some of the barriers that they have. And then let's actually open mobile clinics. So we operate big kind of RV-based mobile clinics that we can rotate throughout the communities that we serve to provide more of an office feel, but not be constrained by any specific location, so that we can actually learn where people go and kind of meet them where they're going. And then through that, as we engage with the population that we serve, we introduce them to virtual care, because not everybody actually has experienced it. And from our perspective, everybody says, well, they don't have broadband necessarily in these rural communities. They may not have cellular devices. Like, they don't, but what a lot of people have? Got a phone. And a lot of people think that virtual has to be this video visit that so many of us have gotten used to over the past 3 years through all the Zoom meetings that we've done. Telephone works really well. The problem with the telephone historically was that providers didn't get paid to actually consult with people over the phone. But because we take on kind of total capitation for the population, we want patients to call us whenever they need something. How do we make sure that, because that's a good use of not just our time, that's helping to make sure that care is being delivered for the population. So again, we've kind of built this model where we try to solve all the big fundamental issues, expand access, do it in a way that meets the population where they exist today, and do it in a way where the payment model fundamentally aligns incentives between the people that are paying for care, the patients that are receiving the care, and us who's delivering the care.
Well, that's really fascinating to hear about, and I want to get deeper into the chief business officer role, but I still have a question around. You just bring up really interesting points about effectively delivering under a value-based care scenario.
Yeah.
Because there have been offers and openings for value-based care for many, many years. And of course, we have a recent iteration with accountable care organizations.
Yep.
And while traditional players have been very slow to catch on, and we don't see as high a percent of value-based care contracts as we could have, this business is based around value-based care. Right. So what are the gaps that traditional players have tended to miss that allow y'all to operate effectively under this value-based care scenario?
Yeah, and I think it's a great question, and I think the inclination is like, what is it? What are people not doing right in the current model? And I actually don't think that's the actual way to think about it. The challenge that if you're a traditional provider has, you're serving multiple different patients across multiple lines of business. When I say lines of business, you may be seeing Medicare patients and Medicare Advantage patients and commercial patients, Medicaid patients, and you're doing it across multiple different payers. So the challenge that you have is, we talk about value-based care as if it's like one general thing. No, like on the commercial space, every different payer may have a different type of program that's what they're actually solving for. It'll look different potentially on the commercial space and the Medicare space. So that challenge, to me, that's one of the biggest fundamental challenges that many people have. I don't think anybody argues with the idea that value-based care is the way that care should be delivered. There's just a lot of just structural constraints to actually make it happen. So we knew that, and look, there's a lot of things when you're coming in as a new entrant that are challenging. But the one thing that we do have is to say, like, we made the choice day one, we're only focused on Medicare. So that eliminated a lot of those other variables that we actually had, because we said the Medicare space will actually allow us to do this. So you're starting to see more and more organizations, and I would say Michigan as a state is a leader in this space. The payers in the state have actually been really collaborative with the providers that exist here, but it is tough whenever you have providers that are kind of split across all these different ways of care getting paid for across multiple different payers. Now, the other challenge that you actually have when it comes to value-based care is part of this is how do you have to kind of go all in, because people talk about this idea of having a foot in two canoes. So it's really hard to say, well, part of my business runs by making sure that I have a lot of visits, But part of my visit, I also get some incentive payment on doing certain things right. So figuring out how you balance that and having a path to move towards something that's sustainable is just tough. So what I'm really motivated by is like we don't view these other entrants, anybody that's in the value-based care space, as competitors. The more people that are actually doing this and trying to change the way that care is being paid for, we think is a positive for everybody. It helps us. It gets the payers more comfortable with paying for care in a different way. It gets patients to understand the value of being in these types of models. It allows even big health systems to start to think about what's their role as they think about value-based care. So it's probably more than you want to hear, but hopefully that gives you some sense of how we think about it.
I just think it's kind of funny that we use this foot in two canoes analogy, knowing realistically that nobody in their right mind would ever put their foot in two canoes.
Yeah, exactly. Right. That's right. So you know how it happens. I mean, you know what happens when you've got that. So that was exactly right.
Cool. So just digging deeper then into it, like, thank you for really describing the role. And it's actually really exciting to hear about this kind of thinking about these new journeys and modalities like mobile clinics and things like that. That's exciting to hear about, and just wondering how the role of chief business officer wraps into that.
Yeah. So what's really, really exciting to me. So when I chose to join Homeward, there were a number of things that were exciting for me about the opportunity. First of all, I love our leadership team. I've had a chance. Like I said, I was a kind of a pain in the butt customer, but really respect a very smart, innovative team of people that are super passionate about what they're doing. And the mission of our organization, so our CEO, she grew up in kind of rural Minnesota. My wife is actually from rural Minnesota, the other side of the state from where our CEO's from. And I've seen the challenges that her family, her parents in particular, just faced receiving care. So for me, coming to an organization that was very much aligned with the mission was really important. But in the role that I play with the organization, I'm basically the one that goes out and talks with health plans about how can we partner? How can we think about ways to solve this problem together? In a way that understanding the constraints and the challenges and the problems the health plans are trying to solve for, understanding what we collectively want to achieve to support this population, and really building out strategies where we can collaborate with folks to do that. So that's what I get to do. And then it's not just with the payers, it's who are the other stakeholders in the ecosystem that we can partner with to help deliver against this really challenging problem. So one of the very first partnership that we actually announced before we announced a payer partnership was with Rite Aid. So Rite Aid, it's pharmacy. Rite Aid happens to have across the country 700 of their locations that are in rural areas. So there's actually been, depending on the study that you look at, some studies actually show that pharmacists are more trusted than than physicians themselves. So when you think about stakeholders in the healthcare ecosystem. So think about us. We're a new entrant coming into a community. People don't know us. Being able to work with an organization that has a trusted relationship with the population. People view Rite Aid as a trusted partner for their health. They also have destinations where people go in those communities. So as we look at locations for us to have our mobile clinics on a regular basis, again, it's eliminating a lot of those barriers that people have. How do we meet people where they're already going? If they're already going to Rite Aid for something else, great, let's have our mobile clinic there so that they know that they can access care while they're there. So that was really critical, structuring partnerships like that. And we're in active discussions with a lot of different stakeholders besides just payers and providers in the ecosystem to think about how we can support the unique needs of the patients that we serve. So that's what I get to do. Hopefully you can see I'm really excited about it.
I can tell.
Just a little bit. So
I'm a little bit excited too.
Yeah.
I'll say this. It does sound exciting to be able to liaise between, okay, so we have this innovative model that's all in on value-based care and then can offer opportunities and relationships and connections that are mutually beneficial between y'all and traditional players. So I think that's a really interesting approach to it. One thing that we had spoken about earlier, actually, I didn't know this about your background, and I was really interested when I heard you talk about it. But you had mentioned where mental health fits into that journey. One concept that we're really focused on at WOBOT is around behavioral health integration and whole health. I'm just curious about your perspectives on it. I've just seen a lot of investment or a lot of attempts at this behavioral health integration concept. Yeah. Just curious on how mental health plays a role in how y'all focus.
Yeah, so I would say, just broadly speaking, there the events of the past couple of years, between the pandemic as well as just things that we've seen as it relates to challenges the population has faced, whether that's equity issues, whether it's just stresses that people have faced, it's been extremely unfortunate. But the one thing that has come out of that that's a positive is there's been a general, I think, destigmatization of mental health and behavioral health. And this, going back 5-10 years ago, getting people to even talk about mental health and behavioral health was something that we just didn't see. There was just a reluctance. It was considered a weakness, as opposed to really addressing the idea that, no, this is just health. I mean, this is not a fault that anybody has. This is health. This is part of health. So as you think about that's been a very positive to see across the industry in general. And just recognizing the number of organizations that are focusing on this, that is a positive, I think, across the board. Now, going back to this idea of value-based care and thinking about, if we're taking on accountability, any organization, whether that's a payer, a provider, anybody that's focusing on serving a population or individual, you can't just think about the sick care that's being delivered for their physical health. You have to think about how all this stuff comes together, because we know that individuals that have chronic conditions, if they have a comorbid behavioral health condition or mental health condition, the likelihood that their outcomes are going to be worse and their spend is going to be higher it's much greater. So you have to think about this from a clinical outcome standpoint, even from a business standpoint. If you're not thinking about these things together, you're not going to be able to achieve the outcomes that you want. So what we've seen within our model, and as we're continuing to support the population, what we're excited to see other people's do, the collaborative care model, which is basically where how does behavioral health get embedded into primary care practices. That's really critical. And it doesn't necessarily need to be that every primary care practice has to hire a psychologist or psychiatrist in their practice, but ensuring that you have the ability to coordinate with those resources as needed is really critical. So for us, one of the things that we're trying to solve for as we go forward is, again, we're not expecting a bunch of providers to move to rural communities. So how can we partner with entities that are in the ecosystem today to ensure that, one, we're identifying opportunities to deliver behavioral health care to the patients that we serve, and then how do we make that super easy and convenient to get the care to the population? I will say I have the opportunity to speak with a number of folks throughout the healthcare ecosystem, and I think what everybody realizes, even though there's a ton of attention on the space, there's just not enough providers. There's not enough people that are doing it. So that's something we just as a system have to think about, and I certainly don't have a solution for that, but it is a real challenge that we as a country are going to be facing, that there's just not enough providers actually delivering the care that we need. So this does then lead to, how do you think about new ways of scaling care? How can people with different levels of licensure deliver components of the care that are needed, to the extent that digital tools can augment some of the things that are taking place? That's really important. And then how do you train your primary care providers to potentially deliver components of care that maybe they would have previously, referred out? So again, big challenge, but I would say it's anybody that is serious about population health or value-based care has this top of mind for them. So
yeah, no doubt. And some of the things that you focus on hit on points such as by addressing these mental health issues more upstream, there is potential to, or have you seen it? Actually, it's a question. Have you seen cost curves or?
Yeah, I mean, it's a good question. I think that we know that there's opportunities there. I don't know. I personally can't cite specific studies that show if you do X, Y, and Z, it actually lowers outcomes. But I think anybody that's looked at the data says, sure seems like there should be, So we definitively know that there are worse outcomes and higher spend for populations that have comorbid behavioral health conditions compared to those that don't. And we know that if you have multiple chronic conditions, the likelihood that you have a comorbid behavioral health condition increases. So that you can't treat them in isolation. So
I'm just slightly switching subjects. I did a webinar last year related to Walmart Health and their entry into Georgia.
Yep.
And a lot of people that were attending that, they were really curious. Like this was back in 2021, and there's a lot of fear around disruptors and things like that. But I feel like you have the opportunity, like having been in the traditional space, clinical space, and now the new entrant space. I'm just curious, like the folks that are watching and just trying to understand how they should be navigating, like in their traditional perspective, or like if they're in that traditional background. What are the things that they should be thinking about related to this relationship with disruptors and these new entrants coming to the market?
Yeah, I think as you think about the healthcare space, there's in general people in the healthcare space, especially people that have been there for a while. Anytime something new comes forward, people get worried. I mean, what does this mean for them? Rightfully so. What we saw the challenges that providers faced over the past several years. When volumes drop, when there's not patients that are coming in. Many providers struggled with how they actually can stay afloat. Hospital systems have had significant challenges in the space. So everybody's worried about what happens if I lose even more of my patient base, if I lose even more of my revenue. And I think there's a couple ways to think about it. One, everybody would love to think that they can do everything. Maybe not, So how do you think about the specific roles that your organization fills? And then knowing where the industry's trying to go with this idea of meeting people where they are, really being much more patient-focused, consumer-focused, understand the expectations of the population, not being constrained by having people show up in the office and wait, an hour past their schedule to get another doctor's appointment, and think about how do we align with the way that care should be paid for. I think there's an opportunity for everybody to really think about how to partner with other organizations and not view disruptors as a disruptor to your business model, but view them as someone who's thinking differently about the way that we solve this healthcare problem, which is a really big problem. So, as an example, we knew that as we entered into markets in the rural space, rural healthcare providers are already challenged. And rural hospitals, a significant number have closed over the past 5-10 years. It would be a really bad idea for us to try to solve the rural healthcare problem by leading to a bunch of rural hospitals going out of business. So that'd be really bad. Mm-hmm. Bad business, bad idea for how we're going to support the population, bad for just the country and the overall healthcare ecosystem. So when we actually went in, and we also knew that the last thing that we want to do is take dollars out of any provider's pocket in the communities that we serve. If there are physicians that are delivering care there, I don't want to steal business from them. I don't want to take any value-based reimbursement that they're getting today. So as we've gone and talked with our health plan partners, we said, you know what? Based off of the data that we've seen, there's just a lot of people that aren't getting any care today. How do we focus on that part of the population today instead of competing for the people that are already accessing the system? So it's going after a population that isn't even accessing the system today, or when they do access the system, they're accessing it in an inappropriate way. They're just showing up for the emergency department. So we've been really intentional about that. And that's a way where we can not all just coexist, but think about this. If we're now serving this population that wasn't receiving care that was probably necessary that they should be getting, we can now coordinate with those hospitals that exist in the communities to make sure that the patients get the services that hospital actually delivers. So we just have the ability to actually do that because, again, the way that we get paid, the way that we can focus on kind of coming at this through a different angle. So I don't know if that gets it fully the way we think about it, but hopefully that's how we're thinking about it and how I would encourage others to think about it.
You're out here sowing seeds. You're throwing ideas. Like there's different people that have different areas of expertise. Yeah. At different organizations that have different expertise. And I think that what this lays the groundwork for is to let's examine that. Let's take inventory of that, and where we're missing in our inventory, that's where we can look into this range of people, range of organizations that are able to augment where we might not be as strong.
That's the way I think about it. And again, it comes back to this idea of partnership. I find it hard to believe that anybody who's in the healthcare space, there has to be a reason why people ended up there, and hopefully it's for this idea of being able to do good, support a population, address challenges that people face. So if anybody that's out there that's in the space, if that's where you are ultimately coming at this from, think about, for you to advance that, there's other people that you can work with to fall back on that piece. And I get it. Like, everybody's always concerned about how do I keep, this the whole no margin, no mission. You got to have a sustainable business, but sustainable business doesn't necessarily mean that you have to do everything.
Mm-hmm.
So,
well, and that when you bring up the word mission, it just makes me think about like the difference that a role that this public benefit corporation can focus on. Was like, we say no margin, no mission, but let's focus on that mission as well. Yeah. But it leads me to kind of my final question, which we ask everyone, is if there's one thing that you could change about the delivery of healthcare or mental health, or et cetera, if there's one thing you could change about healthcare delivery, what would that be?
I'm super biased, and this is having spent 5+ years on the health plan side. But if we could have designed from the day one the way that care is paid for, to not be in a fee-for-service model, and really from the ground up say, this is the way that care should be paid for, and the system would have been built in a way to allow it to do that, so that everybody's incentives are aligned. That's where I'm so excited to see that's where the industry is moving. Everybody says it's not moving fast enough and big enough, but if we were living in a world where incentives were fully aligned across folks, it would. So many of the conversations that we have about the way what's broken in the healthcare system just wouldn't exist.
That's a really big topic, is like, what's the underlying incentive? Yeah. And if we have these incentives that look like they hint at bad outcomes, then they're going to go in that direction.
I mean, the system will only operate in a way that it's however you design it, that's the outcomes you're going to get.
Yeah.
So if you're paying in a fee-for-service basis, people are going to figure out, how do I make the most of that model? If you're not actually holding people accountable for the outcomes, and outcomes can be everything from clinical outcomes to experiential outcomes, making patients wait for appointments, not really meeting them where they are, inconveniencing their lives. If that's the way the system's designed, that's the outcomes that you're going to get. So if we could really rethink the way that, that aspect of it. And there's been a lot of press recently about Medicare Advantage, and some people, concerns that people are gaming the system, or payers have been under the spotlight in terms of some of the things that have taken place. But if you look at the way that the Medicare Advantage was designed, it actually is a fairly elegant model, with this idea that the government's going to pay for people based off of how sick they are and what it actually costs to deliver care. Health plans are actually incented not just to manage the cost of care, but the whole star rating aspect of ensure that patients have great quality, ensure they get great outcomes. If you do those things, you get rewarded to reinvest in the actual product itself. So it is this really elegant model. It's just, if only we could bring that to the rest of the healthcare system. So.
Yeah. Well, I really appreciate that. And honestly, this has been a really energizing conversation. I don't think that anybody watching would be able to tell that this was at 9 a.m.
Yeah, well, thank you for that. And again, I really appreciate the opportunity. The teams that I've had the privilege of working with over the past number of years always say that they tease me because of the energy that I usually have at 7 a.m. when we start our mornings. So I appreciate the opportunity. Hopefully that comes across that this is something I'm really passionate about, and our organization is. So.
And I bet there's going to be people watching that want to reach out. What's the best way to get in touch?
So anybody can reach out to me. So my email, I'm happy to share, but it's Friedkin, Friedkin at homewardhealth.com. Feel free to reach out to me on LinkedIn as well. So happy to connect, talk more about what we're doing. And again, we're really, really big on partnership. So
great. Well, it's been a real blast talking to you.
Thank you so much, Chris.
And the folks watching Meeting of the Minds, we really appreciate you sticking with us in this interview. And we also appreciate the MedTech Health Summit for putting this on together, MedTech Crossroads for setting up the awesome audio-visual setup, this fancy lighting and screens and everything like that. So appreciate it, and hope everybody has a great day.
Thank you.